All right, y'all, let's talk about something that's so common in nursing practice. You're almost guaranteed to run into it whether you're in the hospital, the clinic, or working community health: cataracts. Now, the simple definition: a cataract is when the lens of the eye becomes cloudy or opaque. That lens is supposed to be crystal clear so light can pass through and hit the retina nice and sharp. But when that lens gets cloudy, vision goes fuzzy, like somebody smeared Vaseline on your glasses. Here's why we care. Cataracts are the leading cause of blindness worldwide, with about 18 million people affected. And if you live long enough, your odds are pretty high. More than half of Americans over 80 have them. So yes, this is bread and butter nursing knowledge. How they happen. Cataracts can develop in one or both eyes and at pretty much any age, though age-related senile cataracts are the most common. We also see traumatic and congenital types. Age is the big risk factor, but that's just the tip of the iceberg. When we talk about risk factors, think aging changes, pigment builds up, proteins clump, oxygen uptake drops, antioxidants are reduced, sodium and calcium creep up, and the lens loses its transparency. Eye problems, things like uveitis, herpes zoster, myopia, retinal surgery, or retinitis pigmentosa. Toxins, aspirin, heavy metals, smoking, corticosteroids, radiation, chemical burns. Poor nutrition, especially low antioxidants. Physical injury, trauma, foreign bodies, electric shock, dehydration, UV or X-ray exposure. Systemic disease, diabetes, lipid disorders, Down syndrome, renal disease, some musculoskeletal disorders. How they show up. Classic signs: painless blurry vision, not sudden pain, just a slow fade. Things look dimmer. Glare sensitivity, headlights, sunlight, those bright store lights all become a problem. Reduced contrast sensitivity, decreased visual acuity, myopic shift, monocular double vision, and sometimes a brown discoloration of the lens. Diagnosis. We don't just guess. The severity of vision loss doesn't always match the degree of cloudiness you see in the lens. That's why we do a Snellen chart, ophthalmoscopy, and slit lamp biomicroscopy. Management without surgery. Here's the truth. There's no non-surgical cure. The best we can do is slow them down, stop smoking, control diabetes, manage weight, protect the eyes from UV exposure. But if a patient's cataracts are impacting daily life, surgery is the answer. Surgical basics. Most cataract surgeries are outpatient, take less than an hour, and have a rapid recovery. The main approach today is phacoemulsification, using ultrasound to break up and remove the lens nucleus and cortex while leaving the posterior capsule intact. Small incision, less astigmatism, faster healing. We almost always replace the lens with an intraocular lens, IOL. The old options, thick aphakic glasses or contact lenses, have more drawbacks. IOLs give great vision and have a low complication rate, but they're not for every eye condition. Anesthesia. These days, we often use topical or intraocular anesthesia, no big retrobulbar block, so patients can cooperate during surgery and avoid bleeding risks. IV sedation is an option for the anxious. Timing. One eye at a time. We wait for healing and evaluation before moving on to the second. Pre-op, retrobulbar hemorrhage, rare with topical anesthesia. Intra-op, posterior capsule rupture, suprachoroidal hemorrhage. Early post-op, acute bacterial endophthalmitis, toxic anterior segment syndrome. Late post-op, suture issues, IOL malposition, chronic endophthalmitis, and posterior capsule opacification. Easy fix with a YAG laser. Hanard nursing care, before surgery. Standard same-day surgery prep. Only order pre-op labs if indicated. Always ask about alpha antagonists like tamsulosin. Floppy iris syndrome is real. Dilating drops before surgery. Start teaching about post-op care before they go in. Antibiotic, corticosteroid, and anti-inflammatory drops will be part of the routine. Nursing care, after surgery. Eye protection. Shield at night for a week. Strict drop schedule. Teach what's normal. Mild discomfort, scratchy feeling, slight redness. Teach what's not normal. New floaters, flashing lights, pain, worsening redness, decreased vision. These are urgent. Acetaminophen for mild pain. Watch for steroid-induced intraocular pressure spikes. At home, protective patch first 24 hours, then glasses during the day, eye shield at night. Sunglasses outside. Light sensitivity is common early on. Clean any mild morning discharge with a damp washcloth. Keep follow-up appointments. First ones usually within 48 hours. Vision stabilizes in 6 to 12 weeks. That's when final glasses prescriptions happen. Multifocal IOLs can give great vision, but be upfront about possible extra glare at night. Bottom line, cataracts aren't an emergency, but when they start impacting function, surgery is life-changing. Our role as nurses is to prep, teach, and watch for those red flag complications so our patients keep the vision they've regained.